comfy chair cushions, because this one's going to be rather in depth. So it might make some of your eyes roll back into your head, but bear with me, and we'll try and have some discussion toward the end of our session. So to introduce ourselves, my name is Sun Vega, and I've been doing consulting work for about almost 7 years now in the field of behavioral health. I used to do a lot of work nationally through my colleagues at Open Minds. And so I got quite a bit of exposure working for other nonprofit organizations, large and small, as well as for-profit and even pharmaceutical companies. I did quite a bit of work with market assessment and other research for pharmaceuticals. So that was a lot of fun. But I'm here locally and doing more localized consulting work, and so I really enjoy meeting the providers and learning things constantly from them. So, and then also joining me are Michelle and Michael, and I'll have them introduce themselves. Michelle?
Hi, thanks, Sun. My name is Michelle Welby, and I have been in Albuquerque for several years and a former senior manager for health insurance companies and healthcare systems. I've been a consultant for about 5 years to many of those same companies with whom I used to work. A lot of Medicaid background. I've worked on RFPs for companies for them to get their Medicaid contracts. And in my former life, many years ago, I was the Governor Richardson's health policy advisor when a lot of the Medicaid reconfigurations were going on. So it's nice to be here. Thank you, Sun.
And good afternoon. My name is Michael Spanier. I'm a Santa Fe resident for about 30 years now. Doesn't quite make me a native, I don't think. Longtime state employee, retired from state government about 3 years ago. Primarily, I work for the Department of Finance and Administration in their Budget and Policy Division. Also was both Deputy Cabinet Secretary and Cabinet Secretary of the Aging and Long-Term Services Department. I've been consulting with these fine folks, Michelle and Sun, as well as our fearless leader, Pam Hyde, for about 3 years now, doing a lot of consulting work with New Mexico counties in the behavioral health area, San Juan County, Doña Ana County, Santa Fe County, and of course, Bernalillo County. So glad you could all join us and take advantage of this opportunity. And I don't know, Sun, should I go right into the virtual housekeeping?
Yes, please do.
Okay, so the presentation is being recorded and will be made available. I think Bernalillo County folks, Jennifer and Raina, will be sending it out to you. And if you know of others who might be interested in receiving the slides that weren't available to join us today, please let us know or have them get Jennifer their names. Sun already indicated that folks have been placed on mute. You can unmute yourself, certainly, if there's something you want to say, or later on when there's an opportunity for questions. Relative to questions, we're hoping there'll be some time at the end for question and answer, as this presentation is being recorded. If possible, if you could not only hold your questions, we've created, or Jennifer and her group have created, a chat option. So there's a capacity, there's an icon for chatting. So if as a question comes to mind, it's a burning question, please throw it into the chat box. And we'll be keeping track of those and getting to as many as we can today. If we can't get them today, we will follow up with you with responses to that, to your question. So we want to encourage your use of that. And I think the only other thing I need to say, unless someone else needs to add something, is that the virtual bathrooms are down the hall. They're the second door on the left.
Thanks, Michael. So I want to make sure that we do a time check. We budgeted, well, we booked 2 hours for this, but I don't anticipate that happening unless, of course, we have some good discussion toward the end. But I just want to be conscientious of the time and make sure that we move through this information for you. What we're going to do today is talk about revenue cycle management. And the first thing we'll address are some strategies and ways of thinking about revenue cycle management, and also how to tame your process, because for some folks it's complex. It's difficult to really put the right process or procedures in place. So hopefully we can help you do that today. And also we'll talk about compliance factors to keep in mind. So hopefully by the end of this session, you'll walk away with some practical information that you can just go ahead and move forward and use through your administrative processes at your organization. And not only these will help you thrive, but you'll thrive in a managed care environment, because that's what makes these revenue cycle management so complex and challenging sometimes. And then we'll also hopefully give you some tips and identifying some procedures that perhaps we haven't thought of before that you can put in place into your process. I also want to speak to my own personal experience. I failed to mention that earlier. I was in charge of and had full oversight of a revenue cycle, like a claims department and a team. I had a team of about 10 individuals working with me that was overseeing a department of managers and other coordinating and supporting staff on a statewide basis for claims and revenue procedures. So I have a pretty good sense of what it takes, and I know how challenging it is, and sometimes you want to bang your head against the wall, but hopefully these tips will help you keep you from doing that. So stepping back a bit and reflecting on what it means to do revenue cycle management, to actually involve yourself in this process. It's a skill, and it really takes everyone from your administrators to your clinical staff to contribute into this process, this cycle, because that's what your revenue goes through. If you can imagine, it cycles from your organization through another and cycles back to you in terms of collection and payment, and that's ideally where we want to get you, is that payment. When we break down revenue cycle management, we have 3 components that we can think of. There's your contract management that plays a role. There's customer service, and then the billing aspect behind RCM. If we break those components down, and you imagine that contract management is the oversight of an agreement, and monitoring that agreement and reporting to that particular agreement that you have with a payer like Blue Cross Blue Shield or Presbyterian and Western Sky. So those are our Medicaid MCOs that we would typically be contracted with for services, but they also have commercial products. So we would have an agreement that would capture whatever commercial plan that we might access and receive referrals for our clients. We have customer service, which is a big piece of revenue cycle management. It's not on the face of revenue cycle management, you wouldn't imagine that would be the case, but customer service does play a big role. And then there's the meat, the billing. We have 10 principles, and these are things that I've kind of over time developed, but these are the 10 principles that are really hold true in a revenue cycle management process. And one of the very first thing I try to adhere to is do it right the first time, because it'll save you a lot of headaches on the back end. Collect your money when it's due at the point of service. So when we reference point of service, we mean when a client or a consumer comes in your door or at the point they receive a service. So virtually nowadays, it would be at the point at which they have an appointment online. Eliminating lag times. So making sure that by the time we have a service and the time between that service and the bill that goes out the door, it's as short as possible. Managing our claim rejections, continuing to do that. And then if there's a process this isn't working, let's fix it. Let's make sure we redesign the way we're doing things so that processes are efficient. And it takes teamwork. It takes a lot of teamwork. Everyone's hands on deck to make a revenue cycle successful. And then we're going to make sure that we use technology to the best of our ability, because it'll help save us a lot of time and effort in many ways. And so we'll talk about that a little later. And share data. We want to give people updates about what we're doing and what success looks like for us. And making sure that our controls, we have internal controls. So these are the fiscal controls that we're talking about. And then having, it does take a particular type of personality to manage each aspect of a revenue cycle. So let's talk about some strategies. We have, it is a proactive initiative. I mean, I've mentioned this before. In order for our organizations as providers to be successful, we have to make sure that it's not just a fiscal function or not just an operations function, but it's a program, it's a service function. It should be kind of something that we're talking about openly across departments and with our clinical teams even. Now, and if we don't take care of our revenue cycle, there's the potential to lose a lot of money. And for some that are running fairly efficiently, that potential could only be maybe 2 to 5%, which is actually not bad. But these are leaks that could happen in your own revenue cycle, whether they're direct leaks or what we call opportunity leaks. And our direct leaks come from just a failure to just collect. And then there's the opportunity leak, where there's just flaws in our system that if we just tighten things up a little bit and make things a little more efficient, that we could see an incremental increase in our revenue. And so there's so many causes, and that's what makes revenue cycle management complex, because there are a lot of hands in the pot, so to speak. So there's a lot of folks involved in this process, and so we have to make sure that we're all keeping up our end of the responsibility. And some of those are indirect causes, so they could be a result of we changed our services, we have a new service that we started, and we haven't quite lined up how we're going to bill for it, or we we're in a state of an emergency, and so we're operating in a whole different environment right now, and we're trying to shift everything we're doing and make sure that we're capturing our revenue appropriately. So I imagine that a lot of folks are dealing with that today. And then there's just the direct causes where it's human error, or we have flaws in our process or procedures, or we just didn't set up our EHR adequately to bill. And so these are all vulnerabilities that are common, and but they're also fixable. So when we talk about maximizing revenues, there's some strategies, some common strategies. So these are the 5 common strategies that I see out there. Okay, well, the first thing we'll do if we want to increase revenue for our organization is to just increase our price. Well, some of us don't really have that option, right? What about we just increase our capacity and our productivity? We'll just do more. So a third one is, well, let's see if we can increase our referrals and get more of those in the door. We need more services to be referred to us. And then the fourth one, well, we just need to create another service. Maybe we need to go after another type of care, whether it's MST or some other kind of specialized service. But those have their own costs and inputs related to that. But the fifth one that I think that folks don't usually spend enough time on and think upon is tightening up their payer systems so that they're getting the claims that they're billing out are getting paid the first time they go out the door. And so tightening up a revenue cycle could be a tremendous benefit to an organization that's doing enough of it. And so these are just the factors behind each of the strategies that I discussed. The increase in prices, maybe we'll go out and negotiate higher contract rates. Okay, that's doable too. But this is difficult sometimes because you can't always make very significant gains when you negotiate a higher rate. So when we think about increasing our maximizing revenue through our revenue cycle, managing that, then if we just collected a little more up front like we were supposed to, if we didn't ignore the copay, maybe we should just collect that, and we would see a difference in our revenue collections. And so when I speak about revenue cycle management, I also want to be clear that I'm talking about Medicaid as well as the commercial products that are out there. So we're also having to bill commercial payers for services if we're seeing clients through those plans. So I'll be talking about both throughout today. The other aspect I talked about was capacity, increasing capacity and productivity to help our revenue source. And that's certainly a good way to do it. And we can do that through making sure that, our billing cycles, our scheduling cycle is more tight. We're booking more appointments and making sure that we're following up with clients before their appointments to make sure they show up. Or maybe we would use physician extenders that are, rather than a physician, to see these, to do medication management as an example. So referral generation is another way, and that certainly takes, comes comes with marketing. How do we identify a market or promote our activities a little bit more to get more referrals in the door? Additional services, like I mentioned. So what other services could we provide? That's another way to increase revenue. But I think that, tightening up your revenue cycle processes is something that's that you can manage internally. It doesn't take too much extra effort or too much extra personnel. It's really something that exists today if you're billing for Medicaid or commercial services. And so let's look inwardly and figure out how we can adapt our systems. Because if it's inefficient, then that's something that can be addressed, and you should be getting payment for services that you're already contracted for anyway. So taming your revenue cycle management processes. I say taming just because for many folks out there, we didn't come into this business of behavioral health to manage cycles and systems and processes. We wanted to provide behavioral health care and help people. And so it's for many folks, it's out of your realm to deal with this. And so even for me, it took a lot of time and a lot of learning. I made a lot of mistakes, but I also was able to figure out some strategies behind that. So I'm hoping to share some of that today. There's a lot of pitfalls if you're not collecting what you're due. And if you think about a bad debt ratio, and that's what I see commonly is 20% or more. And these are organizations that are making $1 million in revenue, but still losing quite a bit of money. And if you think about 20% of $1 million bill, that's $200,000 that you're losing out. And to add some additional perspective behind that, it's that could be 2.5, 3 more FTEs of people that I could be hiring to do additional work out in the field or supporting our teams in the office. So here's just another way to look at it in terms of revenue that you could generate through claims and a collection percentage against that. So if you're only collecting 85%, which is I would say an average collection rate for most organizations. It just depends on what type of service you're billing too, because if you're an outpatient service versus a residential service, there's very distinct differences of how you would collect your revenue for those. They're just processed a lot differently by payers. But the goal is to increase your collection percentage so that you don't have to, at the end of the day, write off as much debt, bad debt. And there's the common reasons behind that. When I see organizations that are running at an 85% collection rate, they're obviously doing okay. They're doing, on average, pretty well. But there's some things that we could uncover to address and make sure that we get an even better collection rate. And a lot of times it's because services just aren't covered by the payer. We're billing for services that the payer doesn't really cover in your contract, or we're not getting the prior authorizations that we need. Sometimes it's just a consumer or a client just falls off Medicaid and we didn't really catch that soon enough, or we didn't follow up on any of our denials. Interestingly, there's providers that I've been able to help or support that just once they've sent the claim out the door, They just cross their fingers and hope they got paid. But if it got denied, nothing would happen. So that would be the first place to start if that's what's happening now. And then procedure code setup. So if you have a claims management system, if you're not setting up your codes correctly, then that's another easy fix for your revenue. When we break down the major components, and I mentioned earlier, contract management, customer service, and billing, I didn't include compliance. And I think compliance is something that that's very critical and important for any organization that's doing Medicaid services and billing for them. And so at the end of this series, we're going to talk, this session actually, we'll talk about some compliance factors to consider. So component one, contract management. This is really it starts at the very beginning in terms of when you approach a payer and you decide that you want to bill for your services on this agreement with the payer. Contract management is it's a specialty in and of itself. It takes a particular expertise, and so understanding the agreement, the rates that you could potentially negotiate, knowing that you can opt out of certain plans. That was a revelation for some providers, because you don't have to opt in for all the plans. You can just do, this. You don't have to do Medicare, as an example, if you don't want to. And then, what's covered, what types of providers are available. So these are all things to consider, even at the beginning phases of contracting with a payer, and helpful for you. When you manage your agreements, it's nice to have one person responsible for coordinating all the contracting. And it may be one person that's supporting a manager or some other leader in your organization, so that all the contracting keeps moving along and it doesn't get stuck. And you want to make sure that you get all your agreements centralized in a location, and that someone knows where they are and how to get to them fast. And you want to make sure that you're tracking that performance on these agreements. And when I say performance, and we can talk about, those are some of the data elements that we can talk about later as we start breaking down kind of how is our revenue tracking with each of the payers that we're contracted with. That's an example of tracking performance. And then maybe we have to develop a strategy or a policy around how we manage our contracts around, for a particular payer, whether it's because there's a specialty service that's contracted for, or there's a particular geographic area that we're serving. So there's some consideration for that too. The negotiation, not very many folks like to do it. It takes a special person that can move forward and move on the button with negotiation. So it helps if you have an individual that's working on tracking your agreements and perhaps supporting you to help you figure out how to negotiate them. Communication's also very key. When you get contracted with a managed care entity or a commercial payer or a Cigna or an Aetna, it's also important to just communicate that information to your teams, making sure that, hey, we have this plan that we're in network for now, and this is how we're going to handle it, and this is who can be credentialed with this plan. And so it's helpful to communicate that way you aren't running crosswise in the end when someone in the billing department is trying to submit a bill. Credentialing is a very important. It's just critical, a part of your own contract, and just developing your own network and payer system, and how you're going to bill for services. Because if you don't have your clinical staff credentialed with the payers that you're contracted with, it makes it very challenging for you to collect a payment for a service that they rendered. So we want to make sure that we have someone that's riding herd, so to speak, on that credentialing, and making sure it's happened when someone is onboarded. Probably a new therapist, as an example. So making sure that there's someone that's responsible for managing that credentialing. So let's talk about customer service, because I think that this is an area that we don't often think about as a part of your supporting your revenue cycle. And it's key because of the cross-departmental involvement of just a client, a patient coming and receiving services. It involves everybody. So from admissions, from someone collecting and registration information, to the follow-up after the service has been rendered. It takes everyone's involvement. And so how do we make sure that experience is a good one, not only because for the clinical or other kind of care that you're providing, but also it's efficient, and you're looking like, oh man, these folks know what they're doing. And so that's always important, and that everyone's keeping tabs and communicating. With admissions, that first call or initial contact is important, because you want to make sure that you collect all the minimum information you need to submit a claim. And if that collection's streamlined at the front end, it's super helpful for your billing staff at the back end. Scheduling and referral management. So these are things that if you're in network with a payer and you're contracted, then let's make sure that our front office staff know that when they answer the phone and someone's asking for an appointment, who's in network, and how do we handle their coverage. And they have the resources and tools they need so that they know which practitioners are even credentialed, and how to assign potentially that appointment to that particular practitioner that's in network. So those are just helpful for the front office, when you and making sure that you're getting the client hooked up with a practitioner or a provider, with the right person first. So doing it right first. Insurance verification is another big deal. Making sure that we do that before the patient comes in for a visit. I've encouraged that of my own teams that I've worked with is, hey, we already know who's coming in tomorrow, right? So maybe we should just check their eligibility and benefits information before the day starts. And maybe we can catch up with them if they've fallen off Medicaid, and give them a heads up. And if we can do some case management around that, that would be even better. So that's a way to be proactive about insurance verification. And once you've got your clients, your patients coming in on a regular basis, then maybe it's just checking it periodically, once a month. And depending on your volume, you may want to check it twice a month. So this is the kind of the list of minimum data that you might want to collect. Some more information about eligibility and benefits verification. There's some great clearinghouses out there that can just do it for you. If you sign up, they will just do it for you. I think there's like a per check fee potentially, but if you do like a cost benefit analysis, you'll realize that the time that you have staff doing that eligibility and benefits checks manually, you're spending more with that than paying a clearinghouse to do it for you in seconds. There's a saying, and this is kind of an inside joke that I use, was "Se habla insurance Sherlock Holmes," because for many of us, it was like, what's this language that these people are speaking? I don't even understand what they're talking about when you make a phone call and talking about benefits that are covered. And so there's quite a bit of training that happens, and just, on the ground learning. You have to just do it and learn as you go, because every payer is different. So unfortunately, they're not going to be consistent. But if you're working in Medicaid, which is a government program, that's usually a little bit more consistent, and you can find a little bit more kind of the same language being used, but it gets more complex as you add more payers into the mix. And so training is very important. Understanding what a deductible is, what a copay should be for a particular agreement or plan that you have with a payer. So these are all things that will be helpful and really just kind of move you away from being detective to more of a leader in this area. Prior authorization. So, now with mental health parity and a push for that, I mean, there's still not enough of it, in my opinion, but certainly as we've gained more parity, I'm seeing less requirements for prior authorization, except when we move into the realm of more intensive services like intensive outpatient or residential care. I mean, there are prior authorization requirements for that. And so making sure that we're aware of that, our staff are aware of it, they're trained to get the prior authorization at the time you get a new patient in the door, and to do the follow-up. So indexing the types of payers and services and even down to the code that require prior authorization is important. Another aspect just behind just the technical and administrative prior authorization procedures is just the clinical authorization. And so involving the clinical staff. Some organizations have one person that's a clinician that's really assigned to manage clinical auth, and that's a bulk of their responsibility. And that's okay. It just depends on your organization. But having a treatment provider or someone that has the responsibility clinically to support that process is helpful. Point of service collection. So you see this a lot in like payer training and commercial insurance companies. They talk about POS, and that's what they're talking about is point of service. And that's when a client or patient presents themselves for that service. And at that point, are we ready to say, hey, this is what you're responsible for in terms of a copay, and hey, this is what's going on with your deductible, and making sure that we hold them accountable for their end of their coverage. And so that's what that means is just communicating, being transparent at that point of service, and sometimes if the volume necessitates it, you may encourage counseling as a part of that component of admissions. You'll see, like, if I go to a dentist or my primary care practitioner, I check in for my appointment, and then I'll move over to another window. They'll call me later and do some counseling with me. And so that's the financial counseling component. It's also about, collecting informed consent and getting a HIPAA disclosure and consent signed. And so those are components that we can be transparent about up front. Billing Billing is, like I mentioned, the meat and potatoes of revenue cycle management, and it's a critical part of making sure you get your revenue. But I wouldn't say it's more or less important than any other component, because it does take every piece of that revenue cycle management process to get that dollar in the door that you worked for. Service review and coding is important. Having a billing staff person or team that is familiar with it, what the services are that we render, which ones, they are basically the experts of the system. And so they're working and communicating with your frontline staff that are collecting registration information and demographics and checking insurance coverage. So they are on the behind the scenes for them, unless they're wearing both hats. That happens too. Then that sometimes that's even easier, because if it's the same person, they know exactly what needs to be collected and done. But this is an important component of a billing person or a coder. Understanding what activity codes are available to you, what you're contracted for, how to, there's manual edits. So when I speak to edits, it's really the how the payer might process a claim through their claims system. And so there's certain edits that are in place that may reject a particular claim because maybe you billed too many units, or it wasn't the correct code for the correct provider type. So those are edits, and having those edits and knowing those edits ahead of time is important to make sure that you're submitting clean claims. And upcoding is it's a sensitive issue. You want to be prudent to the point of just avoiding even the appearance of upcoding, because you do not want to be accused of that. It's bad practice, and so we want to make sure that we're correctly coding our services. And I know in behavioral health, when we get our Medicaid fee schedule, we just get a code and there's no description. And so we need to be familiar with the description of the codes. And sometimes that means going to a resource like the American Medical Association, because they are the ones that developed the code, and they can provide the description for us, and making sure that we follow that description. I can't tell you enough that an EHR or an electronic health record or a management information system, whatever that system is that you're using to bill claims, it's so important to leverage a system like that, particularly as you gain in volume. If you don't have very much volume, I can see how it's fairly simple to go online and type in the claim into the payer's own claim kind of interface. But if you're dealing with hundreds of thousands of claims, or it gets very unwieldy, and there's a tendency to make mistakes. And so having a system, an EHR or a billing system that can do it for us is critical. Setting up your codes is important, and having someone that's intimately familiar with your service codes and the fees associated with them. So having your contracts and knowing what they are. We didn't, most practitioners or agencies will bill their usual and customary rate. So whatever your UCR is, you bill that, and then but when you get your reimbursement back, you want to make sure that that you're getting reimbursed the rate that you're contracted for. And so some EHRs have procedures that you can set up in their system that can help you track that. So back to edits. Edits are just an important measure to set up in your EHR if you have one, because it does all the legwork for you, and you don't have to think too much about an annual deductible or this, that, and the other, and how to post it in your system. An EHR can do it for you, as long as you've set it up initially and doing it correctly. And each payer may have some nuance or something different, and so you won't be able to figure that out sometimes until you've sent some test claims. But that's what the payers are there also to do, is to help you test your claims if you haven't submitted a claim before. So we have a lot of nonprofit organizations in behavioral health, and we do charity care. And sometimes that charity care is supplemented through fundraising activity that we do, or maybe it's part of a sliding fee scale. So we can set that up as a payer in our own system, and so that we're tracking how much charity care we're providing, and managing our expenses to that. And gosh, if we're doing that, we know maybe we're adding some in-kind in relation to that. So these are helpful ways to manage around charity care. Claim submission is, it can be an onerous process, particularly for folks that haven't done it before. So, if you've done everything that I've mentioned before in this session today, then you might be able to expect an error rate of about 2% or less if you followed it to the T. But what's interesting is that there's still error, and it's expected. And but at the same time, when you're submitting a claim, you'll know that you can be confident that it's going to get paid and your revenue is going to be coming in that door. New Mexico regulation requires that when we submit claims, that they be paid. If it's a paper claim, it has to be paid in 45 days. If it's electronic, then it's 30 days. And that's part of your payer agreement. And so that's something that in terms of processing time, you should expect. And if it's taking longer than that, and it's through no fault of your own, then you could potentially expect interest because a payer didn't pay it on time. So that's something to also look into and consider. But I do strongly recommend, if you're billing claims, and to bill them electronically, and to also accept payments electronically and post your payments electronically, so that your billing or administrative staff are not spending time just doing data entry, but they're spending their time researching the denials and following up with things that are unpaid, rather than dealing with posting payments. So these are just some follow-up activities that could be done in relation to maximizing your revenue process. Using your frontline staff. I mean, those as a billing supervisor and manager, those were my best friends because they were in tune to who had an appointment the next day, and gosh, can you collect this bit of information for me? And so that's super helpful. And then it also helps to look at your denials, start analyzing the information that's coming in from the payers, and seeing, gosh, what's being denied and what's not being denied. And, is there a trend? Is there some kind of trend that's going on? Is a particular provider maybe? Or is it a service? Or, sometimes it's just they didn't like the claim. And whether it's a glitch on the payer side or on our side, we got to look out for those things. And reaching out to our provider relations person is a first step, and a good next step to reviewing those claims issues. And the last thing I tell folks is breathe. Because these things can wear you out, but don't let them. You have to be relentless. And, I built up my own reputation for being relentless, and maybe that was maybe not so much of a good thing, but at the time it's very critical and important to our organization that we recover our reimbursements. And so how do you be relentless and kind at the same time is important. So reauthorization of services, I won't rehash that. That's just a place where, you have to have a prior auth process and procedure in place, and just keeping up with those and involving the right team members in that process. Administrative appeals, sometimes you do have to get to a point where you have to appeal, and it may be an exceptional circumstance, whether there's a client coverage issue or benefit issue, or maybe there was just a really big glitch that really threw us for a loop and we need to appeal. And so those are things that you can prepare for. But know about that escalation procedure, because it's a little different for each payer, but it's fairly standard in terms of the approach and how the result would occur. And sometimes you can just work with your provider representative, and they can help you, and maybe they can flex a certain benefit or issue and help you manage through it. Tightly managing your accounts. So it's just all of these tips just hark back to being accurate. When you set up your system, whether it's for billing or collecting co-pays, just making sure that we're accurate when we do it, and using technology like an EHR to help us do that, so that we're not depending too much on humans and the likelihood of error. So this is an area, if you're not only doing Medicaid services, but you're providing other third-party payer services. This is a place where it's important to collect your co-insurance from the clients, depending on the plan. I mean, a patient could be responsible for up to 50% of the fee for a service. So you have to make sure that you collect that, or otherwise it's a losing proposition for the organization to provide that service or care. This is not the first time you've heard me mention clinician involvement. So making sure that they can help, and sometimes they can be very helpful interveners. Particularly when there's a balance or delinquency, because it impacts a patient's ability to potentially continue receiving services. And so we don't want to jeopardize that, but we want to be supportive and making sure that we collect balances that are due, because we also have to continue to exist and collect our revenue so that we can provide care to other people that need it. So there's a mantra that I tell folks that is important in terms of holding not only our staff accountable, but also the clients accountable for their share of a fee. So if they have a co-payment that's due, then we need to hold them accountable to that co-payment. And I think it's still the case where we are contractually responsible for doing that. So we have to make sure we uphold our agreement to collect on that co-assurance amount. And so we have to develop a policy around that so our staff follow it and that clients are aware of it up front. So that's being transparent and saying, look, if you owe an unpaid balance, this is the consequence and we need to stick to it. Because if we don't hold our patients accountable for their end of the responsibility, then it encourages a bad behavior, and it also puts us fiscally at risk. So another aspect of controls and managing our finances and our funding and our monies is that when we collect dollars, if we're collecting a copay, we need to monitor those deposits because this is an area of high risk. Unfortunately, what we've seen out there in terms of embezzlement and cases where agencies get taken advantage of is if you don't have the right fiscal controls and monitoring in place, you could lose money in this area. And so monitoring those deposits, making sure that you're saving your administrative expense and time when things can be done electronically, doing it electronically. And then just handling it in a certain time frame. So there's an expectation of when things are reviewed and monitored. It's interesting because I've worked with some organizations that we'll worry about the bad debt and the write-off toward the very end. And what happens is by the end of the fiscal year, as you're balancing your books and preparing for a fiscal audit, it gets very challenging to look at your uncollected amounts and say, what substantiates the reason behind that? And so having basically a policy in place where there's a review and an approval process, whether it's by a supervisor or by committee, maybe it's a group of managers, and you decide, okay, at what point is a claim just uncollectible? We've just done everything we could and can't collect on it, and we need to just write it off because we're just spinning our wheels. The other thing to consider is if you do that, and this doesn't apply to Medicaid clients, but it certainly does if you have unpaid copays or other coinsurance amounts that are due, utilizing a collections agent might be helpful. So our policies, you've heard me talk about policies and procedures. And so these are things that help standardize your process from the time a client calls and asks for an appointment and their new patient to each point of service, each treatment that they receive, and each claim that goes out the door, having those policies in place so that your team, whether it's one person or multiple people, have a way to just operate fairly independently, but also prudently to manage your revenue and your resources. So these are just other examples of policies and procedures that you can put in place. There's just a litany of things that could assist with maximizing your revenues. There's also reports that you can run. So running routine reports will help you track your collections. I personally have never been satisfied by reports that come out of like these canned reports that come out of EHRs or other billing systems. So I typically ask for my own reporting that helps me understand what I'm seeing and in terms of collections. And so, and then you just set targets around that. Your expectation for outpatient services might be well, maybe 95% is not reasonable today, but maybe 80% is, and that's okay. But we want to continue to work toward that target, and then we move the target as we get better. And so this is just a really an example of a report you could use by payer and month. There's some principles to follow. So, you know, these are the ones that I mentioned earlier that I want to kind of reiterate and make sure that, you know, these are some key things to consider. And then there's, you know, that holy grail. If I had enough bandwidth, I'd make this animated so that the goblet's just spinning in gold and shining for you. But it's really, this is where we want to be in terms of making sure that we identify in our revenue cycle management issues early on, before a bill even gets out the door. We want to just address that issue and make that process so streamlined that you know, we don't even have to think about our process and billing. We'll just, the dollars will start streaming in. But that's, you know, that's certainly the holy grail, but that's a goal to work toward. And you know, when we get to this point, your agency, your organization, once you've maximized your revenue, then gosh, it just makes the stress level behind worrying about revenue and whether you're collecting, if that's reduced, then, you know, it just makes it so much easier to focus on mission and you know, what value we're bringing to our stakeholders and our consumers. And so that all of this is just another way to help you be more efficient, be more strategic, and increase your capacity to care. So a short section on maintaining compliance. We have another session scheduled on Friday related to corporate compliance, but this is just kind of a quick synopsis of these points for you. I do want to disclaim that none of the information that I'm going to provide today is legal advice. So, you know, everyone's situations are going to be different. And so I would advise you to seek legal counsel for your particular situation and your jurisdiction. And any of the views that are expressed here on out, you know, please keep in mind that these are really my views and in my own capacity, and not anyone else's. So at 30,000 feet, our compliance program, in terms of a highlight, we have to, and it's a program. I mean, if we look to, and I'll go through it a little later. When we do a compliance program, when we develop something like that, it's really about keeping people involved in the process and communicating and making sure that we're doing the right next thing. And so a lot of these compliance elements, and in fact, all of them really come from CMS. And it is an expectation if you are going to be billing Medicaid or Medicare and other government services, and more and more commercial-based services as well. These are the guidance elements that CMS provides. And so having written policies and procedures, having some kind of, it doesn't have to be a compliance officer per se. It could be, you know, you just a person that's really good at it and is into it and can keep people engaged in a compliance program. That's what you want. And then training and education, which we already do and we have to do for the services we provide. So how do we, elegantly put in some compliance elements as a part of that? And we also have to be clear about disciplinary standards. If folks are not being compliant and are doing things that are out of whack, there needs to be a clear consequence for that. And then just doing our what I call CQI, continuous quality improvement activities. So doing some routine monitoring and auditing ourselves and responding to any issues that come up. So my big question for some folks is, do you have a coding compliance manual? And for many people, the response I get is, what is that? and that's okay. But I think if you had a coding compliance manual or plan identified for your billing staff, and that's something that you can review and update annually because things are constantly changing, that you put something in place, and it doesn't have to be overly complex, but having in particular for coding, this kind of step by kind of a face sheet or overview of a code and the expectations around that code would be helpful. And I do want to keep in mind too that when you are under review or audit, or if an allegation is made against you, these kinds of things are discoverable. So we want to make sure that as we are developing our manuals and our compliance procedures, that we are being prudent and we're sticking to the regulation and the law. There's some elements of developing a coding compliance manual. These are just an example of those. And do compliance, and then there's probably a section about general issues or reporting procedures, and then you have kind of your standards and expectations for your program. So these are still coding compliance is still distinct from a general kind of coding a compliance program that you would have. And these are just some additional elements to consider as a part of your coding compliance. And I've got some examples here. So this one's very, there's a lot of text in here, so I'm not going to read it to you, but everyone will be able to read the slides later. I like this particular snapshot of a code. I've kind of leaned toward this easy to read kind of a coding compliance standard that provides some information about a service and how you would address billing it. And then here's like a table of contents from HRSA. So they have a sample billing collections policies and you can borrow from that and adapt it to your own needs. But this is just a really good a resource to use as well. So one of the anxiety-provoking things about compliance is the issue of being audited. And what I tell a lot of my clients that I work with is, if you know you're doing the right thing, and then you have nothing to really be concerned about. As long as you're following all the steps that you're supposed to in your compliance program, you should be fine. And so if you don't have a compliance program and you're billing claims and services, I would strongly recommend that you adapt what I've provided here for your organization's use, because when it comes down to an audit, then it'll be a breeze, because you'll know what to expect and how to respond. Here's a preparedness checklist I offer in terms of just making sure that, in general, your compliance program, just checking the temperature of it and seeing, okay, do we have that? And are we there yet? And if not, then maybe it's an area of focus that we need to work toward developing. So some final takeaways. Your program and your coding compliance program in particular has to strike a balance, and some of that just comes from experience, and some of it is consulting with your peers about what balance should I strike related to being general or specific for a particular service. And if something's not defined very well, well, don't try to define it. You are subject to those bounds as well. So if you restrict yourself, then you will be holding yourself to a more strict standard than you necessarily need to. And education, training, and onboarding. Gosh, it's if you have particular administration or support staff or teams that should be involved in this process, they should be involved in ongoing education from the get-go. And then if you see a risk, let's team around it and mitigate that risk and work together to resolve it. And so some of that has to do with, just being compliant, and some of it's just supervising. And how well are we supervising our teams or staff around these issues? So there's some key compliance laws that come into play here. This is the major ones that are out there, but I'm not going through those today. They will be. We will go in depth on Friday on these particular laws. And last but not least, just know your payers, know your contracts, and those requirements that come with it. And when there's a time when an audit happens, just take a deep breath and go with it, and be courteous to the auditors, because they are they're at the behest of a greater power beyond them, to make sure that we're doing what we're supposed to be doing. And so communicating with them is important, and being professional. And mistakes happen, so we're only human, and just as long as we're learning from that, that's just the next step for us. So there's a glossary of terms or acronyms here for you in case you get stuck. We tried to consolidate as much as we could here for you. So let's go ahead and take some questions or have some discussion. I think you'll have to unmute yourself. So if you do have something that you want to, or if you have do we have any questions or comments in the chat?
Hi, Sam. This is Raina. There are no questions currently in the chat. I do, however, just want to touch base. It looks like I've got a list of everyone in attendance other than one phone number, and I was just hoping that maybe that individual can identify themselves so we can get you on the list. That number is 505-730-0110.
So if you recognize that phone number, that must be you. So we need to know who you are. Okay,
All right.
well,
No problem.
until we, yeah, and maybe we don't want to reveal ourselves yet. That's okay. So do we have any questions or comments out there? I mean, I'm happy to entertain any thoughts that you have. Well, we've got a quiet bunch. Or you might be on mute and we didn't hear you. So if you are have a burning question, feel free to ask. I'd also like to invite Michelle or Michael if you have any other thoughts or comments to make related to what we went through.
Hi, it's Michelle. I was just wondering if there was anybody out there who perhaps does not understand something about the claims system or electronic medical records or anything. Not everybody's familiar with it. If there's anything that you don't understand about the process that we could help clarify. Some of you are veterans.
I think that's a really good point, because I know that.
Go ahead.
I know that several providers probably aren't as familiar with it because they haven't done any billing. And so, this is hopefully you'll feel safe in asking a question, because there's no stupid question. I think this is a good forum for that.
Most of the questions that I used to get as heading a team of provider representatives, like over at Molina for Medicaid, there was always a concern around clean claims. We think we submitted a clean claim. We didn't. You guys are doing this on purpose. I can tell you that most of the MCOs their feet are held to the fire to have what they call an auto adjudication rate. They want to do everything by computer. They want a claim to go through. The cash flow is not that great all the time about it. So anything that they can get through lowers the number of telephone calls that will come in, or rework, or reinvestigation inquiries, or whatever. But that seemed to be the biggest concern, I would say. Not in behavioral health and physical health. The claims edits for bundling of services was always a big one. That's a biggie. To bill two services, you're seeing your PCP, and then they do a procedure and they submit two different claims, and they would want to bundle it. But clean claims, I mean, are you guys having experience with getting paid on time or not being paid on time? Another thing, I have another client now that doing a lot of contracting for behavioral health. And I just want to throw this out with contracts. Medicaid, of course, has a fee schedule. There's a whole website, a link. You can look it up by, I think behavioral health has its own section, things like dental, anesthesia, those are all separated. And then there's also a quick lookup table that has no description. Some commercial plans, like one that I'm working with, who's another client, they pay using a Medicare pricer, and people get real confused. So I just want to throw that out to this group, that sometimes a commercial plan may say we pay using the Medicare pricer, and then the first question I get is always, I thought this wasn't a Medicare plan. Mm-hmm. So that's a common one that we see out there. Different commercial plans pay differently. So to Sun's point, you really kind of have to know sort of the vocabulary of billing and claims. But again, no question is too elementary, because this is your livelihood when you start billing. So you think of anything later, you can probably email Jennifer and we can work on getting you resources or links or anything else that you need.
Thanks, Michelle. And I think with that parting advice, and certainly with my emails right there. So if you have any specific questions for me, you're welcome to email me. I'm happy to be of assistance. I know for some of us, it's just being oriented to this whole process, so it's a little overwhelming. And so we'll make sure also to get these slides out there and make them available to you. And the video will also be made available by Jennifer and Raina and her team, and so that if anyone was unable to join us today, they can watch this later. All right, well, with that, I think we'll close our